can see your screen.
طيب let's go live. طيب السلام عليكم. I would like to welcome you all to one of the Saudi Society for Blood Disorders webinars. So today webinar will be about an important topic, which is peripheral blood morphology crash course. So this will be a series of 3 webinars. The first one is today, Monday, at 8 p.m. It will be for 1.5 hours, and then we will have the second day will be tomorrow. It will be on WBC morphology and hematological malignancy. The third one will be about leukemia and lymphoma. So it's in summary, it will be Monday, Tuesday, and Wednesday at the same time, which is 8 p.m. Saudi Arabia. It will be using the same registration link you have received. We are delighted to have 3 prominent national hematopathologists who will be giving this crash course. So for today, it will be Dr. Mohammed Al-Mohammadi. He's a hematopathologist and blood transfusion specialist. Also, he's the chair of Department of Pathology at Ministry of National Guard Hospital in Jeddah. So in the coming 1.5 hours, he will be trying to address platelet morphology and the first part, and then the RBC morphology, specifically about the abnormalities. We will try to make these webinars interactive as much as possible. Please type your questions or comments in the Q&A tab. Dr. Mohammadi will try to address them as we go. Again, day 2 will be tomorrow on WBC and hematological emergencies, and day 3 will be in lymphoma and leukemia. I would like to remind you that the webinar is recorded and it will be available on the SSBD YouTube and social media accounts. Lastly, I would like to thank the sponsor, Aput, for the unrestricted support for this event. Without any further ado, Dr. Mohammadi, the mic is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the introduction, Dr. Firas. It gives me a great pleasure actually to talk today. I don't want to call it a presentation. It's a morphology session, something that I like to do, and I've been doing during my practice since I was in training about morphology of the blood cells and how can we utilize this morphology and let it help us in helping our patients. What I'm going to talk about today is red cell and platelet morphology. And I will try to, I tried actually to pick up the most relevant things because as we discussed before, the level of this session is a session for beginners or for easy access to peripheral smear and its findings, and we try to make it practical as much as we can, so you can get benefit from each and everything that we show. And we don't give it for just for the fun of it, but for actually the benefit of it in the diagnosis and helping our patients. So I will start actually in reverse to what is in the program. I will start with the red cell rather than platelets. And I will start by asking the question, what are red cells? So red cells are not supposed to be called cells to start with. They're not actually cells. As you can see here, they came up, came from early progenitors in the bone marrow that has developed to the oldest ancestor of the red cell, the pro-erythroblast, and then keeps differentiating until it reaches a stage when it is an erythrocyte or the mature red cell. You can see here also that during this process, it gets rid of its nucleus. So that's why a lot of textbooks don't call them cells. They call them corpuscles instead, because they have no nucleus and they have no organelles. So they lose all of that. So what do they have? They have a little bit of enzymatic machinery to enable them to perform their sole function, which is oxygen delivery to the tissues. In a normal peripheral smear, you will look from low power. This is a low power view. You go from there, from the thin area or the feather edge, and you go down to find this area that is proper for examining the red cells. This is where the red cells just touching each other, so you can see spaces between them. And you can easily see what we call central pallor. You see this white area in the middle? We call this central pallor. And why is it happening? Because the red cells are biconcave, as we have shown here in this picture. So this part give you this pallor area, or the whiteness in the middle of the red cell. So what are the components of red cell morphology, or how do we look at red cells? We look from different angles. First, we look at the red cell size. We all know in the field of medicine that the red cell size and a cumulative red cell size comes to the MCV in your CBC. This MCV will help us in the classification of anemia to macrocytic, microcytic, and normocytic. The MCV is the collective size of the red cells. So the size of the red cell by morphology, we will come into that, is something also we judge by looking under the microscope. And with time, you develop the skill of really getting it right. That when you look at under the microscope and you judge these red cells to be large or small, you look at the MCV and it goes perfectly with that, then you're happy. The other thing is red cell shape. So the biconcave look of the red cells that we have shown in the normal smear, and with no weird and funny shapes other than this. And then the red cell hemoglobinization, which is can be looked at from CBC point of view, or red cell indices, in the MCHC. And it says how well the cells are filled with hemoglobin. This is another way of classifying the anemia to hypochromic or normochromic. And we will come into that also when we look at this, pictures. Another thing that you will look for is red cell inclusions. So the things that can be inside the red cells, and you can see them as, you know, dots or more, you know, things that deviate from the normal look. Starting with the size, because you don't have a ruler when you look at your under the microscope, you have to use a reference to see, to look at the red cell, and you see it, and you say, okay, I judge that the red cell is large because of this, or small because of this. And mainly the classical thing that we use is the nucleus of a small resting lymphocyte. As you can see here, the size between the red cell and the lymphocyte is the same. So you go in the peripheral smear and look for a small lymphocyte, compare the size of your red cell to this. So if it is smaller, then it's microcytic. If it is larger, then it is macrocytic. Another way that I've learned, but not a lot of people you know, use it, is if you are able to stuff 3 red cells, more than 3 red cells inside the neutrophil, then, you know, these red cells are small, because you can put 4 or 5 red cells inside the neutrophil. That means that they are small already, so that you can put a lot of them inside. If only 3, then you're fine. If you can only get 2 inside, then this is macrocytic. This is less reliable, but I have seen people use it. So this is how we judge the size. Then you look at the MCV. If the MCV goes along with that, then you're well skilled and you did that right. Then the shape, we mentioned the shape. So this is the normal red cell. As we can see here, the central pallor does not go beyond 1/3 of this area, okay? This is the central pallor. The size is normal, it's okay. The microcyte, of course, is smaller. The macrocyte is larger. And then macrocytes are divided into 2 kinds of macrocytes. And this is where we start to get, you know, how things are significant or can help us clinically. There are 2 kinds of macrocytes. You can have a round macrocyte like this one, and oval macrocytes. Oval macrocytes are associated with etiologies like megaloblastic anemia and MDS, whereas the macrocytes, the round macrocytes, you can see in liver disease, hypothyroidism, and some other causes of macrocytic anemia. This is very important. Now, what we mentioned about the hemoglobin content, or how much hemoglobin is there in the red cell, you can see it here, hypochromia. As we said before, so the central pallor should be like faint like this, and does not go beyond 1/3 of the size of the red cell. Here you start to have hypochromia, and the hypochromia can be graded from +1 to +4. I'm not sure if anybody is doing that routinely, but you can. It's enough to say that these are hypochromic red cells. So this is the hemoglobin content. Then you have the shape. This is the nice normal shape, and now you have all of these different shapes. Now let's agree on a few things. Each one of these shapes, before we go into details about them, you're allowed to have a little bit of them in your red cells. I mean, if you open the atlas or you go read an article, it would tell you, you know, for normal human blood, you're allowed to have a little amount of target cells. You know, some acanthocytes are permissible, helmet cells, even the fragments, okay? So what matters really is the quantity. If you have a lot of these things, whether in combination or one of them is really, you know, increased in number, and take it like a reference range. Let's say if you look at the red cells, yeah, you're allowed to have up to 2%, 3% in some cases, like in schistocytes, 3% of your red cells, you know, in the form of schistocytes. Okay, that's okay. The quantity is what matters. But we have exceptions. I mean, For the sickle cells, one sickle cells means everything. You don't have to have huge quantity of sickle cells to get the conclusion. The same thing with hemoglobin C crystals. So this is the hemoglobin C crystal, and this is the hemoglobin SC, which we call the pita bread kind of cell. So the presence of these in your peripheral smear means something, and you don't have to have them in quantities. For the other things, for target cells, I mean, you can open the atlas and look, and this is not the aim of this lecture actually is to go in a textbook style and go over the causes of each one of them. But we can talk about the major things. For target cells, you can see them in thalassemia, in chronic liver disease, in post-splenectomy, hyposplenism. Acanthocytes, these kinds of red cells, you can see them also in post-splenectomy. You can see them in cases, I mean, when they are really increased to a major degree, this can be seen in a rare condition called A-beta lipoproteinemia. They can be seen also in plenty of conditions. Now, fragments, these are the two things, helmet cells and schistocytes, as you can see, they're both categorized as fragmented red cells. Again, I mean, when they are really remarkable and really increased, striking feature in your peripheral smear. So we like to think about MAHA or microangiopathic hemolytic anemias because of their huge implication and because there is, emergency treatment, plasmapheresis in case of TTP that you need to do as soon as possible. So you need to really raise the attention to this. But in plenty of conditions, you can have a little bit of them. You can have a little bit of them in MDS, in post-splenectomy, and many other conditions. Ovalocytes, here in this reference, it's called ovalocyte, but generally we call them either pencil-shaped cells or cigar-shaped cells or elliptocytes. I don't like to use the word ovalocyte because it might be mixed up with the macro-ovalocytes. The macro-ovalocytes really is something, it makes you think about MDS and megaloblastic anemia as a cause of macrocytic anemia. Whereas here it's an ovalocyte, but within the normal size. So these will not increase your MCV, will not give you high MCV. These also are seen in plenty of situations, in thalassemia, myelofibrosis, iron deficiency anemia. But if they are increased, like more than 60% of your red cells are in this shape, then you have to think about something called hereditary elliptocytosis. Teardrops, most of the time it's linked to myelofibrosis or any bone marrow, heavy involvement like in solid tumors or bone marrow fibrosis. But again, in small quantities, you can see them in plenty of situations, including thalassemia, MDS, myeloproliferative disorders, etc. Yeah, a few things also about the inclusion. So we have talked about the size, hemoglobinization, shape, the inclusions. Most of what we need to concentrate on is the Pappenheimer bodies and Howell-Jolly bodies. While the Howell-Jolly bodies are remnants of the nuclear DNA, Pappenheimer bodies are remnants of the iron. And both can be seen mainly in hyposplenic state or post-splenectomy. Together with the mix, remember, post-splenectomy we mentioned can have a little bit of this, little bit of that, target cells, acanthocytes, fragmented red cells, you can have a little bit of teardrops, can have everything. And I want to tell you something about post-splenectomy. Always remember that the spleen serves like the filter of blood. So it filters, it takes away all of these defective forms that are not normally allowed to increase to a high number or high percentage. When the filter is lost, then all of this garbage and defective forms, they benefit from the situation and they just increase and fill your peripheral smear. Basophilic stippling, this is also a form of red cell inclusions that you can see. But you know, the classical example is lead poisoning, but this is really, you know, people are not using lead pipes for water supply for decades, so you're not supposed to see that much for lead poisoning, but there are other reasons. We put them together under the category of dyserythropoiesis. So anything that affects the erythropoiesis inside the bone marrow can give you basic stippling. So again, it can be thalassemia, it can be MDS, and other entities when the main pathology is happening in erythroids. I want to go, you know, over this, you know, more, and probably if we spend an hour talking about these things and giving examples, we'll not finish. But what I want you to know is that really quantities matter. You're allowed to have a little bit of them. And they can happen in combination. When there is a lot of all of the kinds of them, you think about post-splenectomy, the loss of the filter that filters them away. We will come to examples and go over some of them. So again, morphology need to be taken in the context. You have to look at your CBC data, clinical data, link all of that together with the leukocyte and platelet morphology. So you cannot go, you know, looking at the red cell morphology. I mean, sometimes when the etiology is hemolysis, you're looking at, you know, you're suspecting something about red cells. But conventionally, I mean, and this what will my colleagues talk about in the subsequent talks, you look at red cells, white cells, and platelets, you know, in a conventional way, so you don't miss anything. Of course, you have to give more attention to any striking feature that is really remarkable, but you have to always go in a classical conventional way, look at all of these components. Maybe there is something that will help you to give a conclusion to the clinician, or something to look at that will help him to deal with the patient. Before we switch to cases and to try to make it more of kind of interactive as much as we can, I will go over some of these questions here. Difference between MCH and MCHC and which is more reliable. I mean, there will be a lot of questions out of the scope of this you know, talk. We're talking about morphology more than anything else. And we can, you know, talk later about red cell indices to be able to cover all what we have to cover. How can you differentiate between schistocytes and thrombocytes? Yeah, I mean, they stain like red cells. The schistocytes stain like red cells. Look at the red cells around you, and the, you know, the platelets are of pinkish color. Yeah, questions about auto-analyzers and other things. So I think we might go back to these questions, but I prefer now to go with the questions, with the cases, sorry. Now, this is case number 1. No history or clinical findings given. So what do we see here? To make it more interactive, I would like you know, our colleagues, our attendees to write something about it. What do you see? Okay. Okay, so obviously we see fragmented red cells. This is what we talked about. Yeah. Try to minimize this. Opening the chat is not. Okay. I think we went down. Okay, so red cell fragmentation is one of the emergencies and one of the main competencies that I would like everyone, as much as we can, like all of our trainees, internal medicine, family practitioners, hematologists, of course, to be able to recognize this picture. You see a lot of fragmentation. So instead of the nice red cells like this one, there's huge number of these fragmented red cells. This is a helmet cell, fragmented, 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 helmet cell, fragmented. So when you look at this, the kind of reflex that you should have, you think about what we used to call before microangiopathic hemolytic anemias, or MAHA. Now it's collectively called thrombotic microangiopathies. We like to think about TTP and roll it out, looking at renal function, asking about the patient, looking for thrombocytopenia in addition, and making sure that there is really no abnormality in coagulation, because this is what will differentiate it from DIC. When DIC, you can have little bit of fragmentation, but you have abnormal coagulation profile. So you need to recognize the condition, because you can use a life-saving plasmapheresis for this TTP patients. But red cell fragmentation, as we said before, can be found normally in small quantities in normal blood. And again, it can be seen in thalassemia major, hereditary dyserythropoietic anemia, hereditary pyropoikilocytosis, and this is another hereditary condition that affects the membranes of the red cells. It is a member of the family of hereditary elliptocytosis, and we will come to an example. So all of these hereditary conditions can give you fragmentations, and also can be seen in megaloblastic anemia and post-splenectomy, MDS, or anidis erythropoiesis, and can also be seen in cardiac hemolytic anemias, especially when there is a leak, perivalvular leak, will cause turbulence in the blood flow inside the heart, and give you fragmentation. And can also be a result of direct thermal injury, like burns. Okay, case number 2. So it's giveaway. These are the sickle cells. And this is another thing that people need to be good at. You have no options other than being able to recognize the sickle cells when you see them. So it's not, it does not look like the ovalocyte, because it has, sharp end from both sides. This is another sickle cell. And you can see also the target cells, increase in target cells. Some spherocytes, you can see, as I said, you can have a little bit of everything in many conditions. So when you see sickle cells, does that mean only one thing, that it can be SS, or it can have different genetic makeup for this disorder, for this sickling disorder? You can only see it in sickle cell disease, like SS. No, you can actually see sickle cells in sickle beta 0, sickle beta plus, and SC disease, when you have S and C at the same time. So when you see sickle cells, it doesn't mean SS all the time. Okay, let's switch to, this is another finding that I would like also people to recognize. So when you see something like this, this is what we call the hemoglobin C crystal. This is hemoglobin C crystal, and again, you can see a lot of target cells. So this is hemoglobin C disease, CC. And this is kind of the main finding or the almost pathognomonic for hemoglobin C disease. Case number 3, we have a 70-year-old male with fatigue and abnormal gait. And this is his peripheral smear. This is, I think I give it away because it's something that comes up in every stage for in our medical career. Starting from mid-school, they bring you the hypersegmented neutrophils, the large red cells or the macrocytes, as you can see. You can see here a little bit of teardrops as well. That's why I'm telling you it, teardrops means something only if there is a lot of them. If there is plenty of them, then you can think about myelofibrosis or myeloproliferative disorders in general. Red cells are large, hypersegmented neutrophil, so very diagnostic and very helpful to diagnose megaloblastic anemia. I think this comes starting, as I said, from medical school. I guess you can recognize here how big is the red cell. I didn't bring you a small lymphocyte, but comparing the neutrophil to the red cell, I mean, if we use the rule that normal red cell size like this one, you can put 3 of them inside. But for this one, you can hardly, 1 can fit here. So a lot of these, and we can see that not all of them actually large, but a lot of them are large, like this one, relatively this one, and this one. These are the macrocytes, and they are macro-ovalocytes rather than rounded macrocytes. Okay, case number 4 is a case of low-grade hemolysis and splenomegaly. Can anybody tell us what do we see here? Okay, I'm getting, this is great. I'm getting a few answers. Wonderful. So typically, yeah, people will come with variable degree of hemolysis, splenomegaly. A lot of them will be, depending on the disease, will be diagnosed early, but I have seen a few people, especially during my training, made it to adult life, and they got this, diagnosed when they are adults. So this is hereditary spherocytosis. The spherocyte does lack the central pallor we talked about. See the central pallor here? These spherocytes do not have them. And the reason for that, we will say it later. Okay. But hereditary, when you see a lot of spherocytes, you need to think about hereditary spherocytosis. But there is another thing. You need to make sure that there is no much variation, because you remember, this is a genetic disorder. So the red cells should have some homogeneity. Like they should be, you look at them and you feel that they are all belong to the same family or almost look the same. I mean, there are still some normal ones with central pallor that are not spherocytes. But in general, the size, everything, they don't look, but if you look at spherocytes and you can see this, anybody knows what are these pale or bluish, kind of bluish cells with the spherocytes? Exactly. So these are polychromatophilic cells. So what is the kicker here is that when you see a lot of spherocytes and they are almost similar or close to each other, you don't see a lot of heterogeneity. You think about hereditary spherocytosis more than anything else. But when you see spherocytes and you see polychromatophilic cells, you need to think about another thing, which is autoimmune hemolytic anemia. The bone marrow, because the bone marrow is healthy and it's okay, likes to produce these early soldiers that are not ready yet to take the fight. They release them prematurely from the bone marrow to the peripheral blood, so you can see them. And because they have some RNA, they are a little bluish and they stain different from the red cells. So you see a lot of these beside the spherocytes. So we have spherocytes due to autoimmune hemolytic anemia on the right side. We have spherocytes due to hereditary spherocytosis. And now this is taken from the Atlas of Hematology. This basically tells you that there are 3 mechanisms for formation of spherocytes. So you end up having a spherocyte that has no central pallor, but the mechanism is different. Intrinsic abnormality, which is the hereditary spherocytosis, when you have deficiency in the proteins that make up the red cell membrane, you have a problem in this membrane, and the spherocyte will form because of the ratio of the volume to the surface area will be changed, and the red cell will become this shape. This is in hereditary spherocytosis. In thermal energy, you don't lose part of the plasma membrane because of the mutation affecting these proteins. No, because of the direct damage, but the result is the same. You get spherocytes, but they're usually microspherocytes. Again, also in case of autoimmune hemolytic anemia, what happens is that these red cells are coated with antibodies. They go to the spleen, the FC receptor, in the macrophages, try to bite them and take them away, but he end up taking only part of the membrane. The red cell will reform again, or تتشكل من جديد فتتكون عندنا spherocyte. So spherocyte is can happen due to 3 mechanisms at least. This is kind of the schematic diagram for the red cell membrane, and you can see here the proteins. So in general, the proteins that are involved in the vertical structure of the proteins in the vertical structure will give you hereditary spherocytosis. The ones that are involved in the horizontal formation give you hereditary elliptocytosis and hereditary poikilocytosis. It's hard to go over the details in such a morphology session, but just to go over the application of the morphology on this. So we have talked about spherocytosis, and we talked about the different 3 mechanisms that give you spherocytosis. One of them is hereditary spherocytosis. Within this family of red cell membrane or membranopathies, we still have few other entities. Anybody can tell me what does this look like? Exactly. So as we said before, these are the elliptocytes, and the elliptocytes can be seen in a variety of conditions in variable amounts. I forgot to tell you that and those who are in the hematology lab know that very well. We kind of grade, and we have a grading system to look at these forms of red cells and grade them. So when someone reads the report, he knows how much increased are these forms. And the grading system, there are 2 grading systems. Some people go with the numbers, like they will tell you there is +1 elliptocytes, +2, +3, +4. And others will go with the not the numerical one, but would rather say that there is slight increase in elliptocytes, mild increase, moderate, severe, or remarkable increase. So we call this remarkable increase because in no normal person, you should see this amount of elliptocytes. Here it exceeds really, 70, 80% of the red cells. They're all oval in shape, and some of them are really pencil or cigar shaped. And when you look at this, your direct conclusion should be hereditary elliptocytosis. So these are the two most common membranopathies: hereditary spherocytosis that we started with, and hereditary elliptocytosis, and hereditary pyropoikilocytosis, which is a member of the elliptocytosis family, but it is a little bit special. And here are the proteins that are mutated or deficient in each case. And we have shown before the schematic diagram that shows the arrangement of these proteins in the membrane, in the red cell membrane. 75% of the inheritance of hereditary spherocytosis is autosomal dominant. In case of hereditary elliptocytosis, it's autosomal dominant except for HPP, which is the hereditary pyropoikilocytosis. Usually it's combined heterozygous. Now this is a case of 20 years old, female, unknown case to your center with hemolysis parameters and microcytic anemia. And having this peripheral smear. Any thoughts? Any thoughts about this smear? I mean, you can give a couple of differentials, there's no problem at all. Okay. So I got megaloblastic anemia, I got teardrops, I got beta thalassemia, I got TTP, post-splenectomy, elliptocytosis, dimorphic picture. Okay. So I would agree with this as a differential diagnosis. A lot of people, as I said before, all of these findings, you can see them in a variety of conditions. But what we have here is mainly, you see some fragmented red cells. This is fragmented, this is fragmented, but not the fragmented that looks like TTP. And they don't have a very sharp ends in like TTP. And another thing, overall, the red cells are getting smaller and smaller. This is something I don't expect you to appreciate easily because you don't have reference here to compare with. But you can see that these are the platelets. Platelets are supposed to be very small. Some of these red cells are, little bit bigger than the platelets, as you can see. So we have fragmented red cells, and look what is in the background. A lot of elliptocytes. The background is made of elliptocytes. Does that make it any easier? Yeah, so Muhammad Eid got it, it's HPP. I mean, we talked about it in the previous slide, and we said part of the hereditary elliptocytosis is HPP, hereditary pyropoikilocytosis. Because of the small size of the red cells, they're often microcytic. And it will give you a microcytic anemia. And this is one of the rare things that hemolysis usually give you, or the parameters of hemolysis gives you usually macrocytosis because of the increase in polychromatophilic cells. The only hemolytic condition that can give you remarkable microcytosis. And microcytosis like in the level of thalassemia. And people who say thalassemia, I think this is okay also. But in thalassemia major, you need to see a lot of nucleated red cells. This is not happening here. And you need to see also more variation. But here you can see elliptocytes, fragmented red cells, and small, very small red cells. So this is higher hereditary pyropoikilocytosis, which belongs to the family of hereditary elliptocytosis. Case number 5. 55 years old male with long-standing history of ITP, failed many treatments. And this is what we have. The answer is there, but I'm kind of want to keep everybody awake. Okay, so this is what hyposplenic state looks like. As I said before, a little bit of acanthocytes, target cells, and more importantly, the Howell-Jolly body, as you can see here, Howell-Jolly body. Fragmented red cell, variation in size of the red cells, as you can see. The size range is very huge, from small to almost macrocytic. Fragmented red cells of all sizes, and acanthocyte and target cell. So this is how, and most importantly again, when you see this Howell-Jolly body, you think of hyposplenic state or post-splenectomy, the first thing that comes to your mind. Again, to remind you that the spleen is the filter of all defected red cells. Having no spleen will give chance to all of these things to spill out of the body, and fill your peripheral smear. Case number 6, 55 years old female found to have anemia and thrombocytosis. Her hemoglobin was 10, MCV is a little high, 105, platelet 700, WBC 7, and there is mild fatigue. The spleen is enlarged. You look at the peripheral smear and you see this. First of all, the combination of cells, this is why I said before, you don't look at the red cells alone, you look at the red cells along with the white cells and the platelets and the picture as a whole. So what do we call this picture in general? Exactly, I think Bushra got the right answer. It's leukoerythroblastic picture. The presence of myeloid precursors, you see these are myelocytes. They're not supposed to show up in the peripheral blood. They are only in the bone marrow. They come out in very special situations. And when they go out with nucleated red cells, if you remember the red cells before they get rid of the nucleus and become mature like these orangey ones, they are these ones that are supposed to be in the bone marrow, they spill out. One more thing you can see here is some teardrops, maybe not very appreciated here. Polychromatophilic cells. So mainly you see erythroid precursors and myeloid precursors in the peripheral blood. That's called leukoerythroblastic picture. And the leukoerythroblastic picture has a differential diagnosis. So it can be seen in thalassemia major or any overwhelming hemolysis. The bone marrow is really just challenged because of this hemolysis and spitting out everything. It does not differentiate between nucleated red cells or myeloid. And it can happen in bone marrow infiltration, mainly by solid tumors and in some hematologic also abnormalities. But The classical picture of leukoerythroblastosis you can see also in primary myelofibrosis. And in case of primary myelofibrosis, in addition to leukoerythroblastic picture, you see a lot of teardrops. Any other secondary fibrosis, whether it is due to a hematologic disorder, like for example, megakaryoblast, leukemia, or MDS with fibrosis, or other conditions, or fibrosis in cases of MPN like CML, PV, it can give you also leukoerythroblastic picture. And also overwhelming sepsis, like we said, overwhelming hemolysis, overwhelming sepsis just makes the bone marrow react, crazy and spit out all of these nucleated reds and myeloid precursors. In case of GCSF, sometimes also you induce a leukemoid reaction and make the bone marrow sometimes overreact and throw all of these things out. So this is another, a picture like post-splenectomy, leukoerythroblastic picture. These are the things that collectively can give you a differential diagnosis. Case number 7 and the last thing, and I hope it's not the last thing because we have only a few minutes to go over the platelets. What is this? Exactly, these are bite cells, and they're associated mainly with G6PD, but they can happen with any Heinz body formation anemia. There are a group of anemias that are caused Heinz body anemias, and they're usually hemolytic ones. And the following slide will explain what happens. So these are the Heinz bodies. The Heinz bodies are pieces of denatured hemoglobin, and this denatured hemoglobin will accumulate, and when it passes through the membranes of the spleen, a piece of it will be bitten away, and you will end up with a red cell that is called bite cells. So any cause for Heinz bodies, and there are plenty of them, not only G6PD, can give you bite cells. Okay, now we'll go to platelets. So we talked before about red cells, and we said that they are not supposed to be cells, and they're supposed to be called corpuscles rather than cells. Now, what are the platelets? Platelets are actually much less than cells because they are best classified as fragments. So nobody really calls them cells. At least the red cells get upgraded sometimes and giving the number, either erythrocyte or red cell. Platelets are fragments, and as you can see here, they come from the megakaryocytes that are only in the bone marrow normally. Then the cytoplasm of this megakaryocyte divided into pieces, and these fragments become platelets, and they disseminate through the bone marrow sinuses to peripheral blood. Platelets are less complicated than red cells, but they have value. I mean, you need to know, how to use the platelet morphology and what are the things that are beneficial. At some point in hematology, platelets, when people did not know the function of the platelets, at some point it was called the dust of blood. So nobody knew what are they until we learned more about hemostasis and their role. This picture here shows a lot of abnormalities in platelets, while A here, it shows normal platelets. You see they're colored this way. They have a stain, purplish azurophilic stain. The size is usually smaller, much smaller than the red cells. Okay, so if we just exclude the quantitative abnormalities, and we look at the morphology, A is supposed to be, this is what's supposed to be the normal morphology. Before we go into abnormalities, let's talk about important subject. One of the, another thing that is similar in its basic, it's part of the basic as much as the hypersegmented neutrophils and macrocytic anemia is the pseudo-thrombocytopenia. So this is a common question for internal medicine, for hematology. And depending on how strong your mid-school, our mid-school is strong enough that our students also know this common question, is when you have thrombocytopenia, what would be your first reaction? Especially when this thrombocytopenia is totally unexpected. You have to rule out pseudo-thrombocytopenia or the formation of platelet clumps. So these platelet clumps, when they go into the analyzer, they will be counted as one, and they give you a false low platelet count. So this is an important thing. Where do we look at? Where do we look for them? At the feather edge or the end, the thin area in the peripheral blood smear. What is the solution? Instead of EDTA, we use citrate tube to collect our CBC because this is known to be an EDTA related phenomena. How the platelet also can help us? The platelet size will help us in the workup of inherited thrombocytopenias because there are disorders associated with larger platelets with macrothrombocytopenia, and there are ones with microthrombocytopenia or small or normal size. And also the variation in size. Like are their size similar to each other? Here, for example, although they are falsely decreased and will be read as thrombocytopenia, but you can see that they are similar in size. When you have anisocytosis or variation in size, that can have significant, that can be significant. So here, as we said before we go to abnormalities, we need to go over the normal. So normal platelets, as you can see, contain fine eosinophilic granules that may appear scattered throughout the cytoplasm or concentrated in the center. The size is smaller than the red cell, much smaller, and this is it. You can have hypogranular. Now, as opposed to this one, you see here, these ones lack the granules, but in different, different degree. Not all of them uniformly lacking the granules. This one is empty, this is half full, this one is okay. The size is different. So again, yeah, this can be seen in MDS, but not specific to MDS, can be seen also in MDS/MPN. Giant platelets, we call them giant only when they are larger than the red cell. Like this one is definitely, we call them, there is no agreement about these things, but commonly we call them large when they are around the size of the red cell, but giant, they're definitely larger. And this one is larger than 2 red cells, for example. So the causes are either due to increased platelet destruction like ITP, TTP, DIC, hyposplenism, or as I said before, the hereditary thrombocytopenias that are associated with large platelets, like Bernard-Solier, MYH9 related diseases, gray platelet syndrome, GATA1 related diseases. Red cell, platelet anisocytosis. You see here the variation in size. The variation in size is huge. You have something close to the red cell, which is large. We don't call it giant because it's not bigger. And normal platelet. This anisocytosis, again, it's in variety of conditions, but at least, and this is the main thing, it tells you something about the nature of thrombocytosis, whether it is due to a disease or reactive. I mean, we tend to think always, or most of the time, when there's increase in platelets, but they are all the same in size or close in size, or there is no variation, then you don't have to think about one of these conditions. MPNs in general, especially ET, of course, you will have this anisocytosis, which is the variation of size. This is one of the loved slides about large platelets, and it talks about MYH9 previously called Megaloblastic, but Megaloblastic is one of these related diseases. The gene is MYH9, or myosin heavy chain gene. This mutation gives you clinical features of deafness, cataract, renal impairment. The syndromes are, variable in, what is affected in the patient, more of cataract or deafness or renal. But this loved image is showing the large platelet, the dolly body-like inclusion in the neutrophil. These are, when you see this, you definitely have to think about MYH9 gene-related abnormality. Another loved thing is the gray platelet syndrome. As opposed to MDS when they are hypogranular, here they lack the granules completely. You see them empty, as opposed to the pinkish azurophilic. And they're somehow similar in size because it's a mutation, so it affects all of them equally. You don't have to see a lot of variation of size and variation of granulation. So the gray platelet syndrome, one of them. Generally, it's larger platelets, but not huge or giant. In summary, for the platelets, few clinical scenarios, we are looking at platelets, and they significantly help. In pseudo-thrombocytopenia, as I said, I find the major help in reactive thrombocytosis versus MPN or myeloproliferative neoplasms. In reactive, we said the size is similar and there is no much variation in size or anisocytosis. In MPN, usually there is variation in size. And in hereditary thrombocytopenias, it's important to categorize the size of the platelets. Are they large or small? With that, I finished actually my slide and my talk. And we still have time. That is why I would be looking at questions. I will take a few questions before I end. And it's actually very difficult to get used to be asked when giving morphology session, because most of the fun of the morphology session is that we ask the questions and we put the people on on the hot seat, and we show them something and we try to ask them, what is this? What is the differential diagnosis of this? It is more difficult actually to do the virtual form, and it is the first time that I do a virtual morphology session on this scale. So I want to apologize, by the end of this session, if this came below your expectations or it didn't serve you or help you the way I was hoping it, to be. As I said, it's a challenge for all of us, and I wish, inshallah, to see you all in person, and we do more of these. And we will help us also to improve our experience if there is anything to add. Now, let me go over, if there are few questions that I can go over, and if I find them suitable. So is blood film, the questions are moving. How to know the type or the cause of spherocytes while the results under the microscope is the same? There is no way to tell the cause of spherocytosis, as I said, but looking at under the microscope, as I said, if the spherocytes are kind of similar in size and they are little, you don't see a lot of heterogeneity or variation in size. And there is no much polychromasia. You think about hereditary spherocytosis. When you see polychromasia or the other features of autoimmune hemolytic anemia, or you see a lot of fragmented red cells in case of thermal energy or burns, because in burns you will have microspherocytes plus fragmented red cells, as we said before. The differential for fragmentation is thermal injury. It's a clinical diagnosis. You look at the spherocytes and then you have to do your homework clinically to see fits with which category, which diagnosis. What is the accurate procedure to estimate platelet from blood film? Yeah, it's you need to look. These guidelines are written and distributed by the International Society of Lab and Hematology, and a lot of harmonization groups published their data. So you look at the high power field and you count the platelets, and then you can have an estimate morphologically. But I hope nobody of us will really rely only on this. You will have, at least with the peripheral smear, you'll have a CBC. Now, the instrumentation and troubleshooting the instrument is out of the scope of this talk today. So that's why I will not go over it. Yeah, the questions about the platelet instrumentation is a totally different subject that we will go about it. Here we are giving people the, we'll try to develop some skills looking at what's really relevant and will help us clinically. And when we look at the peripheral smear in terms of red cells and platelets, I don't claim that I covered all of the important subjects, but some of them will be covered by my colleagues in peripheral smear or hematologic emergencies through the peripheral smear. Yeah, there is a good question about RDW. So RDW is basically, in a simple word, is the variation in size. So when your morphologic skills develop enough, when you look at the peripheral smear and you see variation in size in red cells, you need to look at the RDW, and the RDW will also be high in proportion to this. It helps me, the situation that I always look at the RDW when I try to sort out if this is microcytic anemia due to thalassemia minor or thalassemia trait versus iron deficiency anemia. In thalassemia trait, basically because it's a mutation and the red cells are affected equally, you have to see low RDW, meaning that the variation in size in red cells will be very minimal. In iron deficiency anemia, the RDW will be high. And in many dyserythropoietic situations, like in MDS, for example, the RDW will be high, etc. So yeah, so it means the variation in size, the range of variation. For the case of the HPP that we have seen together, the hereditary pyropychocytosis, you expect the RDW to be, close to 20, which is a very high. Very long question. In case of TTP, do we need to have only isolated fragments, RBC, without any evidence of pychocytes like teardrops, target cells that are significant to call TTP? Okay, in TTP, you need to be very careful. I mean, if you're lucky, you will look at the peripheral smear and you will find it full of fragments like this, okay? Then you open the lab information system, there is renal impairment, thrombocytopenia, and the coagulation profile is normal. You give a call to the clinician and he confirms by, the patient has fever, all of these things, neurological symptoms, etc. People can be saved. And they will insert the line he will have plasmapheresis as soon as possible, and the treatment course will, will happen. If you have very few fragments, that does not rule out TTP, because sometimes it takes time to increase. So if someone is thinking about TTP, look at the peripheral smear on daily basis until you really rule out that this is TTP. We have seen cases that are missed, TTP cases that are missed, because people looked in, on admission at the peripheral smear, and there were only a few fragments or fragmented red cells. It was not very impressive, but later on, because the peripheral smear was not reviewed again, it was full-blown fragmentation. Can we assess platelet size by morphology, as sometimes it's false and it comes normal at large size in machine due to EDTA sometimes? Yeah, I mean, again, you don't have a ruler to measure them, but things are relative. I mean, if you have normal red cells or normal size red cells, like normal MCV, okay, what we call large is something that is closer in size to the red cell. Giant when it is bigger than the red cell. How is that relevant? As I said before, to differentiate between decrease in production. Usually they are not large in size. Like if it is a plastic anemia, if it is leukemia or something like that, you won't see large platelets. If it is peripheral destruction like ITP, TTP, all of these things, you see larger platelets in general, including iron deficiency anemia for unknown reason. You can have thrombocytosis and large platelets in iron deficiency anemia. In hereditary thrombocytopenias, again, there are entities that are associated with macro thrombocytopenia or large platelets. So you will receive a call from the pediatrician telling you, I'm suspecting Bernard Solier in this patient. Do you see large and giant platelets? He will be looking for that. Another thing that I always, I find it the most helpful, most reliable is reactive thrombocytosis versus thrombocytosis due to myeloproliferative neoplasm, ET, MPN, other things. This variation in size will happen in MPNs, but not most of the time in reactive conditions. Okay, I think with that, I will be finishing here. I hope again that I did not disappoint you or have been much below your expectations. The improvement will come from your comments and what will you have to say about our talks, and it is guaranteed that you will enjoy much more with my colleagues in the coming days, Dr. Haytham Khougir and Dr. Nahla. Thank you everyone. Thank you for being with us, and inshallah we will meet you all tomorrow. Assalamu alaikum.